she, her, pronouns, white woman with graying brown hair and glasses, and I'm lead staff for the Medicaid Advisory Committee, or the MAC. And this is the MAC's public meeting for January 2026 to help fulfill its federal and state mandates to advise both the Oregon Health Authority, or OHA, and the Oregon Department of Human Services, or ODHS, on how to run Oregon's Medicaid program. And I'm going to share a few logistical announcements before we get started. We ask that you mute yourself if you're not speaking. If you're joining by phone, we ask that you mute yourself if you're not speaking, and please avoid putting the meeting on hold. If you have to go, it's better to hang up and rejoin the meeting. MAC members, we're going to ask you to raise your hand using the raise hand button if you have a comment or a question, or you can put a note in the chat to let us know. So the Medicaid Advisory Committee has built in time for discussion after each presentation. We'll have MAC members speak first, and if we've exhausted all the questions from MAC members, if there's time remaining for the agenda item, we can take some general questions. We also have 10 minutes for public comment at 10:15. We have ASL and Spanish language interpretation available for today's meeting. You can pin the ASL interpreter's video by clicking on the More button next to their name, and there's a button for interpretation, which is where you'll find the Spanish language interpretation at the bottom of your Zoom screens. And with that, I'm going to hand it off to MAC co-chair Heather Jeffress to take us through her last meeting. Heather?
I know. Thanks, Sarah, for reminding me. Thank you, everyone. Yes, this is my last meeting. I have done my full 6 years of service here on the Medicaid Advisory Committee. It has been wonderful and went by very quickly. So who knew? And so I appreciate that. And I am leaving in the seat of co-chair. Now, it doesn't just when you're co-chair doesn't mean it's your end. It's actually your length of service that determines your end, regardless of where you are in your service in the committee. So welcome committee members and members of the public. Right now, we're going to go ahead and move forward with our roll call. And we always have a little reminder now, if folks feel that they have any conflicts of interest, to please declare those at the beginning of the meeting and let us know so we can understand your level of participation that day. Appreciate that. And with that, we'll go ahead and start the roll call. Dr. Ahmed, who I believe is let Sarah know she's going to be late. Is that accurate? Okay.
Yes, that's right. And
Okay.
she's our newest committee member, and because of the time between when she got appointed and now, she couldn't quite clear her calendar, so she will join us late today.
Thank you, Sarah. We're looking forward to meeting with her. All right, Dr. Caroline Barrett.
Good morning. Hello.
Good morning. Director Emma Sando.
Here.
Thank you. Hillary Prochat.
Good morning.
Good morning. Jerry Weeks.
Here.
Welcome, Jerry. Kaya Adams.
Present.
Thank you. Kelly DeVore.
Good morning, present.
Thank you. Lydia Dennehy.
Here.
Thank you. Stacy Shaw.
Present.
Thank you, Stacy. And Peter Starkey.
Here.
Thank you, Peter. Good to see you.
Good to see you.
All right. And with that note, building off of what Sarah shared, Dr. Ahmed is our newest member. I was just going to do a little intro for the rest of the members since we have quorum. I believe we have quorum. Yes. Everybody.
We do have quorum. I also wanted to check in. Is Shannon Buck here?
Oh, I'm sorry. I missed one. Shannon Buck. Thank you, Sarah. Need to put my glasses on. All right. I do
I'll
not
let you know if I
Shannon.
see her pop in.
Okay, perfect. Thank you. Apologies. All right, and just to do a little, before she's here, just a little pre-introduction for all of the Medicaid committee members. Dr. Ahmed is an experienced dental director, so we're very excited to have our dental position filled on the MAC. Yay! And I hope we all give her a warm welcome. She's the dental director at Multnomah County Community Health Center, which is the largest FQHC oral health program in Oregon. Dr. Ahmed is a dentist from India who completed their DDS at the University of Colorado Springs of Dental Medicine. And Dr. Ahmed is the recipient of the 2017 Local Impact Award from the National Indian Health Board. So we will be very excited to have her participation and to have our dental position filled on the committee. So we'll have to all help make her feel welcome as she arrives. So with that, let's get back on to business. Committee members, you have received draft minutes from our most recent regular meeting. Please take a moment to review those minutes for any errors or omissions. Not hearing anyone. Did folks have enough time to take a peek? Okay. If there's no further revisions, also just a reminder to call to attention as part of the motion that I hope all of you have had time to look at the consent agenda and the content of that. Again, the consent agenda is where we bundle a variety of items that are ongoing items so that we can be a little more efficient with our meeting cadence. Okay, do I have a motion to approve the December meeting minutes and to acknowledge our consent agenda?
This is Lydia. I move to approve the meeting minutes and acknowledge the consent agenda.
Thank you, Lydia. Do I have a second?
This is Hillary. I'll second.
Oh, thank you, Hillary. I think we got here, Hillary. I think Hillary beat you, Jerry. All right, any objections? Any abstentions? Hearing none, the motion carries. Thank you, everyone. Appreciate your reviewing the materials. All right, and with that, our next agenda item is the director updates, but I do believe Director Sando was going to have to leave. Is that correct, Sarah?
No,
No? Okay. Yay. All right.
unless somebody wants me to leave.
No, I don't want you to leave. I would like you to be here to do your presentation. Thank you very much. I must have had a miscommunication that and something came up and that you were not going to be able to be here. Okay, so with that, I will give the floor to Director Sando to give us our Medicaid division update. Thank you so much, Director.
Thank you. And Heather, you will very much be missed in that co-chair role. But we know that you're not going far.
No.
And so we'll continue to call on you and enjoy hearing from you in future MAC meetings. I hope you won't become a stranger to the MAC. I'm here to talk today about three major things that are happening in the Medicaid space. 2026 is a year of implementation for a variety of new changes that are required by federal law to as part of HR 1 and in other spaces. So the One Big Beautiful Bill Act that passed last about 6 months ago includes significant changes to the Medicaid program, including work requirements beginning in January 1, 2027, and a transition to more often redetermination process to ensure that people who are on Medicaid are going through the process to verify pieces of information about themselves that would ensure that those people are still eligible and enrolled in the Medicaid program. This is a really significant change for Oregon in particular, who has really worked hard to ensure that we don't have churn of people falling off Medicaid due to paperwork reasons and reasons of not supplying particular bits of information. So we have been working hard on those implementation. We haven't gotten a lot of information from the federal government quite yet on the federal standards and how we can ensure that we are meeting those federal requirements. However, we continue to work with our federal counterparts to ask questions and try to get a better understanding of how this complex set of policies is intended to be implemented. One note is that the January 1, 2027 date was set in law. And in law, also there is a provision that if the state is working towards implementation and has made a good faith effort to implement, but is having technical issues or other issues that prevent implementation going live on day one, that the federal government may grant states a good faith waiver to delay that implementation date. We have yet to hear any news from CMS on the good faith waiver process and what entails making a good faith effort towards implementation. So our focus really has been on working towards those implementations, knowing that we don't know exactly what the criteria may be from the federal government for approval of those waivers. So a lot of information is available on our website and will continue to be updated. We've had quite a number of Forward Together webinars with a lot of partners. I think 500 folks showed up yesterday to one of our webinar partner events where we provided additional information about our implementation to date. But the key message at this point is that in 2026, there aren't significant changes. The work requirements aren't yet in effect. The change to 6-month redetermination, et cetera, is not in effect. I am getting a little bit of a Zoom indication that I might be frozen, but I think you may still be able to hear me. I can see how you can give me a thumbs up that you can hear me still.
I can hear you, and then
You're
you just
good.
had a very tiny freeze. It was not that.
Okay. Thank you. Secondly, we do have the start of our legislative session here in February. And it is a short session for even numbered years. It's a very quick session of them, lots of activity in the month of February and into very early March. We are gearing up for a lot of that activity and continue to work with our legislative partners. I feel like in the February update, I'll have a lot more specifics about what is potentially being asked of the department and what changes we expect. A lot of the focus generally of short sessions is more budgetarily focused, but as we get more information and understanding about what the changes might include, we will continue to update you all. And then finally, and I may call on a colleague here to help me out because I'm still not able to see buttons on Zoom on my end. But as of February 1st, we will be having a transition in Lane County. Pacific Source is leaving Lane County, and for members, or most members, with the exception of American Indian, Alaska Native members of of tribal communities. This process is automatic, where the transition will be from Pacific Source to Trillium in beginning on February 1st. And there's quite a bit of transition of care work that we have put in place to ensure that people who are receiving certain services, whether that be physical health services, dental services, behavioral health services, are being transitioned on an appropriate timeline so that their care isn't interrupted. And we have some specific information about that my amazing colleague Jerry, who I believe is on, can maybe share some visuals. And I just want to give a shout out to Jerry, who's been working really hard to make sure that our communities across Lane County in particular, but as well across the state more broadly, are aware of this transition, and that we're monitoring the provider networks and ensuring that people have access to care, and has done an exceptional job in doing so. And so Jerry, are you maybe able to share here?
So I wasn't prepared to share visuals, but my colleague Jessica Diaz did drop in the link, our website where these visuals would be. And on that website, we do have a couple of PowerPoints that explain these transition of care rules, what that looks like for different populations, along with we have presentations that we recorded that have ASL and Spanish interpretation with them. So folks have access to those, and our member FAQs, which does walk through what the transition of care looks like for individual people. We have those in English and Spanish up on that website at this point.
Thank you, Jerry, and apologies. I was ready to share some of your excellent PowerPoints on the screen, but I seem to be having technical difficulties, and definitely need to get that checked out. So, oh, and now I'm unfrozen. Here we go.
Well, thank you so much for those updates, Director Sando, and appreciate the extra input there, Jerry, also. And just one quick question. I know we're a little over time for this segment. Is there a timeline of when network adequacy and check-ins will happen between OHA and Trillium taking on? Because I think, what are they, almost tripling? They're almost tripling their capacity in Lane County. Is that correct?
Yes, and we've been working closely both with Pacific Source and Trillium to monitor their network and the change in networks to ensure that the transition is running smoothly. We have a lot more information on the website, and I apologize for going a little bit over, but there's a transition of care period for physical health, dental health, and behavioral health of 60 days for members with OHP, and then for those with that are dually eligible, there's a transition of care period of 90 days that for those services, so that if people had appointments and whatnot, that they are continuing to get those services as if in the limited circumstances where a provider is out of network of Trillium, but is a network of Pacific Source.
Well, thank you. I did take the chair's prerogative there. It was not your fault for going over. Thank you very much. All right. Appreciate the update, and thank you for those timelines. That's very helpful to understand the process. Alrighty, so our next agenda item, number 3 today, is an update from our sister association, the Beneficiary Advisory Council, the BAC. And so Lydia Dennehy, I believe, is our designated person to give us an update on what's going on in the back. Thank you, Lydia.
Yeah, we had a good meeting. If you want to go to the next slide, we had a selection of things from the roundtable. So we had one member bring up that San Francisco is suing processed food companies and was interested to know if Oregon would consider a similar move to fund healthcare, particularly around diabetes and obesity-related healthcare. There was concern about the head of Jackson Care Connect leaving. They were there at the founding, and so transition will be different, new. And there was concern about the Pacific Source to Trillium transition. Several families have received new cards, but not every member is on the card, or not every family member is, or the birth date is incorrect. And some anxiety among families with children with disabilities that the income waiver will disappear in 2027, causing hard choices and a vicious cycle of, well, if we make too much money, maybe we shouldn't, and then we don't pay taxes, and then it costs, we have an even harder time making our budget. So those were roundtable items. Next slide, please. We had a request to take the yearly income into account for work hours requirement to help people who are gig workers or small business owners whose income fluctuates wildly from month to month. And then the funding cuts hurt community-based organizations and reducing their services and capacity just when people are turning to them more. And in migrant communities, parents are reluctant to take even children that are born here to care. And so how can we provide care? And we had the people suggest mailing medications and making sure that telehealth is available to those families. And that federal cuts threatened access to healthcare. Next slide, please. And then we covered a bunch of topics, and the consumer assessment of healthcare providers and systems. We got a review of the survey results and gave feedback about the priorities that the FACT members would like to see for the data sharing. And then we did a poll where we surveyed members for what we want to focus on. So ensuring access rose to the top, protecting eligibility was next. And we're looking forward to an HR1 presentation in February. Next slide. We have actually gone through quite a few different things for building the council. We went over the charter, and we had consensus on adopting the charter and the bylaws as well. And we worked on our operational procedures and got consensus. We actually are very, the group works well together. And we worked on our rules of engagement and adopted those as well. Coming up, we'll be selecting group chairs and deciding exactly how we're working with the MAC and how we're going to mentor and onboard new members. Next slide, please. So yes, the rules of engagement we're working on, and then working with the MAC membership and onboarding and selecting of group chairs are the order that we'll be working on our upcoming business. Next slide. And that was it. We had a group that really enjoys the consensus process, so we are excited to do that together. That's it.
Well, thank you, Lydia. I really appreciate that very thorough update. That was, you guys are doing so much work and building the organization, and I'm sure all of the MAC members are very excited to hear how you want to leverage the strengths of both committees on recommendations and needs, and how we will really support each other in moving forward things that are critical for consumers and access to care. So really appreciate that, and really exciting that you're getting all your infrastructure in place. That's wonderful. Are there any questions from any other MAC members for Lydia? Okay, if not, let's keep moving forward so we can stay on time with our agenda. Again, thank you so much, everyone on the back. Really, really appreciate your service. Okay, our next item is the Oregon Health Policy Board update. We will have a brief update on the work of the OHPB to help align with MAC and OHPB interests. So just a reminder for Medicaid Advisory Committee members and members of the public, the MAC is placed within the structure of the Oregon Health Policy Board. So again, just like we have our sister association in the back, the MAC works very closely with and advises and supports the work of the Oregon Health Policy Board. So just for a little context. All right. Okay, thank you. And with that, Peter Starkey.
Hello, everyone. Thank you, Heather. Peter Starkey, I use he, him pronouns, and I'm one of the liaisons from the Oregon Health Policy Board. And I know that we're running a little on time, so I'll be super quick. But I do want to start off with Heather. You're amazing, and I will definitely miss your leadership, but I know that you will continue being a leader in Oregon. So I know that you won't be far, and expect me to bug you because I'm going to bug you. So the Oregon Health Policy Board this fall aligned our priorities for the next year, and it was a very lively conversation because there's a lot to talk about, especially with Oregon's federal response and everything that's going on with the federal government. OHPB landed on 2 priorities that we wanted to focus on for this next year, with specifically our time, but then there's also a little caveat with the MAC being something that we have particular interest in over the next year. So our 2 priorities that we're really focusing on this year is a continuation of affordability in the healthcare space. Oregon really is trying to rein in at all levels when it comes to healthcare costs at every level. And we established 2 committees that are focused on industry experts, but then also membership at large, and especially those that are most impacted by increases in healthcare costs, to be able to look at, are there strategies that we can implement and levers that we can use in coordination amongst all of the systems, to make sure that we're on top of that and we can act quickly. The other focus that OHPB started this fall and is looking to make some rapid action on is specifically around primary care. One of the things that really came up a lot in outreach and engagement from community members with OHPB last year was the fragile state of the primary care system here in Oregon. And it really became apparent when it came to our site visits in local communities around the state, and through individuals coming and doing public testimony, that primary care really needs attention from multiple different facets, from a workforce angle and workforce retention and recruitment, all the way up through the administrative burden and all the things that we place on primary care that make it more difficult, and all of the ways in which we can try to make that entire system thrive and grow. So that is a committee that's being established and stood up to be able to have a rapid response to that. It's something that we're hoping to be able to take the work that's been done at a lot of different committees and the cross-sectionalities, gather it and get it into the hands of state leaders and priority areas, and hopefully also legislators to be able to start making meaningful change. The way in which we are continuing our very close relationship with the MAC is that OHPB recognizes and is definitely looking very carefully at the changes that are happening to Medicaid, and the impacts that federal funding has on our Medicaid system, on the CCOs. It's also something that we acknowledge that the MAC does a really great job monitoring. So we are taking a very special interest in making sure that we are connected with the MAC, that we are looking and making sure that we are informed and prepared in case we need to act as well, to be able to support and raise up the MAC committee's work. So that's something where we're keeping an eye on everything and know that the work that you all are doing and the accountability that you have, and definitely encouraging that as we continue forward, the MAC has always been very much in communication about, hey, we're noticing this thing, and raising that alarm, raising that notice. So making sure that we can act quickly on that because things are changing rapidly. We also acknowledge, and one of the things that we're going to be looking at closely and in coordination with MAC is when it comes to CCO procurement, which had been delayed from its original period, and the changing landscape when it comes to CCOs, where they are participating, and when it comes to funding, definitely keeping an eye on that and making sure that we're prepared to be able to support OHA, the CCO system, and especially members. And ensuring that when it comes to eligibility, which is on every single one of our minds, ensuring that Oregon continues to hold the high standard of making sure that people who do qualify are enrolled. That's one thing that I always like to talk about, especially in public spaces, is that Oregon does a really good job at enrollment, and Director Sando and her team and the CCOs really do an amazing job at Oregon being the leader in that space, and working with the MAC to continue supporting OHA and our CCO partners to continue making sure that anyone that is eligible is able to be enrolled. So that's definitely something that we recognize is that the MAC is doing and not wanting to duplicate efforts, but we're going to be in close coordination and communication and making sure that we're here to be able to listen and bring back and keep everybody informed.
Well, thank you, Peter, and thank you for that recognition for the role of the MAC and also the hard work that our enrollment and eligibility and determination units at the Oregon Health Authority have put into the last few years, ensuring that we have the infrastructure to enroll all eligible Oregonians into the plan. So, because they have done an immense amount of work, which has been great to see. Thank you so much. I really appreciate that update. Okay, any questions for Peter? If not, we will move on to our next one. No questions? Okay, and we can always have time later too to chat. All right, our next agenda item is the Coordinated Care Organization CCO 2024 metrics presentation. Very excited to hear about this. And please, if you have questions, make sure we ask them. And we have a great team here today to talk about CCO metrics. Hold on a second. So this really shares the measurement of CCO performance in targeted incentivized metrics as a way of gauging, one of the ways to gauge quality care for Oregon Health Plan members. And with that, we'll have Derek. And Derek, is it Reinke?
Reinke, yeah.
Thank you. I got it right. All right.
Yeah, thanks, Leah. You did great.
And he is the manager of quality metrics surveys and reporting team at the Oregon Health Authority. So thank you so much, Derek.
Yeah, thanks for having me this morning, and welcome to all. So yeah, Derek Reinke, use he, him pronouns, work as a manager in health analytics, and really that's my longer title, but really it's the CCO metrics program. There's a quality incentive program that is some bonus dollars that CCOs can earn based on some quality metrics, and I'll kind of give an overview of that and dive into a few. So next slide. For this group, I don't need to define CCOs or Medicaid or CMS probably, but sometimes we start that basic. But basically, the idea is when in that very first waiver, 2013, that kind of where CCOs were developed and born, there was also an idea that we need to have some kind of quality gauge. We need to make sure that having these more localized investments and dispersing the dollars that way can't come at a cost of quality, so that there would be some set of metrics that would be followed and some bonus dollars that could be earned in that way. And it was first part of the waiver. Since then, it's actually become more of a CFR, something at the federal level that lots of other states are replicating. They haven't necessarily replicated our CCO model exactly in terms of the regionality of it, but some bonus incentive dollars made available is something that's going on in some other states as well as Oregon. So next slide. The volume of this is a little over 4% of all per member per month payments. So, the Oregon Health Plan is about a $7 billion enterprise organization, and 4% of that has been a common amount that's available for bonuses, and that's been over $300 million the last 3 years. So it is some pretty big dollars that are available that CCOs can earn based on performance. Next slide gets in a little bit of how the breakdown goes. So there are 15 measures. In 2024, there were 15 measures. You kind of start missing out on some dollars if you've not made the mark on more than 25%. So CCOs are able to miss a few before they really start seeing, some unearned dollars. OHA can't retain any of those unearned dollars, so there is kind of a secondary way of distributing. So if there's some unearned, then those get there's a challenge pool, which is kind of the way to spend out any remaining dollars in the pool. The next slide shows how CCOs did this financially through the program this last year, the last available year. We're still calculating. 25 will be calculated this summer. But if you'll see some of the CCOs that end up with something like a 2 or 3% range, that means they miss some measures. And you'll see some others here that are above the 4.25, which means that they likely met their measures, and then also some in the challenge pool. So they earned some of that remainder that for example, Advanced Health here did not, or Columbia Pacific, that were a little bit lower performers.
Apologies, Derek. What's the highest percent that they could earn? 5?
There is a hard cap at 5.
Okay.
Yeah.
Okay.
So the 4.25 is a functional high cap because there needs to be room to be able to spend for them to earn a little bit of that remainder. But yeah, the federal reg is very firm at 5% would be the absolute max. And it's going to be probably, we can't always fund that. So there's been a number of years where we've been at that 4 or 4.25. But that really, there's some Oregon match there of general fund and some other things that have happened this last year where CCO rates had to be increased quite a bit more than was budgeted. So there's the 25 payout is actually going to be gauged more around 3%, and the 26% is still kind of up in the air right now. I see a couple of hands up, so I can pause here. I'm not sure who was first, sorry.
Caroline was first and Kelly was second.
Hi there. Do you have the number of metrics each of these met? A slide showing what percentage of the metrics they're meeting? Out of curiosity, I see the dollar amount, but I'm curious how many metrics the CCOs are meeting.
I do. I will drop a link into the chat that has a more full accounting of that. But yeah, so that would mean,
Thank you.
So advanced care might have been, 9 out of 12, or sorry, 9 out of 15. You don't see a penalty until you're below 12. So then for them to be, at that level would have maybe been about 9 or so. But I'll drop something in as a full accounting. I don't think I have that on the slide. Kelly?
Yeah, thank you. I wanted to just call out, I'm with Pacific Source. I can't remember who else on the MAC is representing a CCO. I would just want to be cautious about the language that this money goes to the CCOs. The reality, at least for us, I can speak to, the money goes back out to the community and to provider partners. And I think that's a really important distinction instead of stating that the CCOs get this money, because we don't retain these funds. They go back out to our provider partners and the community that's supporting members. I think that's super important.
That's true. And we have some reporting on that. The average is about 85% of these dollars do go back out to provider networks or other ways through value-based payments and other kinds of ways of incentivizing the work at the provider and network level. So yes, I mean, as far as OHA knows, we hand them to CCOs, you know, functionally. But yes, that's correct. There is some reporting back, and it does appear that most of that gets out to the community, and really is a vital piece of keeping some of the smaller outfits, especially solvent and in the community.
Appreciate that. And Derek, I'd just say for future, this is really great information and particularly salient as we face austerity in the future. And Kelly, you raise a great question of perhaps the kind of data to work with Sarah to help prep Derek about really looking at how different pots of money are expended and invested in the community as we enter more fiscally austere times in the future, so the MAC can really do its role of supporting and informing the plan, which is delivered by the contract by OHA, but really delivered by the CCOs in the community. So that's a great question, Kelly. Thanks for a clarification for bringing that up. And I see Caroline, and we do want to make sure we let Derek
Yes, sorry, just one more thought on that about then the money then going to the providers. These funds then are then critical to hiring staff that support, I'm a family medicine physician, that then support the clinics, hiring staff that help us meet the metrics. So it's a circular loop in some ways, but the incentive payments are then critical for allowing us to do the work to help us meet the metrics.
I would go to the next slide, which I've kind of covered the content here already. It's another view of kind of CCOs, what percent of measures they're typically meeting. So just kind of a little bit of a look back there. Next slide gets us into a little bit about who chooses these metrics and how that's done. So also in 2013, as this all was formed, there was a metrics and scoring committee started, and that's still going. And what the group that I manage most closely staffs this committee. There are 9 members, 3 CCO seats, 3 measurement expert seats, and 3 at-large members. And we've tried our best, especially recently, to really do outreach there to try to get some community members in those seats, some OHP members maybe directly, or folks that are working maybe at a CBO that helps sign up people for OHP, or closely working with those populations to really try to get a bit more of that kind of consumer voice and representation on the committee. But that's the current makeup of the group. Their choices, next slide, are of a couple of different types of metrics. The downstream really comes from the CMS core set. We tried to do a bit more there just for kind of standardization and a lot of things that we need to report to CMS anyway. So the choices that are kind of clinical in nature, well child visits and immunizations and various screenings. Some are preventative in nature, certainly, but things on the CMS core set are we're calling downstream and kind of clinically based. Upstream are quite different, a bit more kind of Oregon homegrown, maybe addressing some particular issues here in Oregon, or certainly trying to get a bit more at potentially non-medical factors, things that are more systemic inequities. So things like our meaningful language access that's trying to equal out and access to healthcare and have an equity focus there, or the social determinants of health screenings and really trying to refer people to things with transportation needs and housing needs and some of those kinds of things. We also in the upstream are screenings for kids that are entering state custody, so like foster care. So they've come in based on some traumatic situation, really no fault of their own at all. So how can we as a system really make sure that they're getting screened for needs and that's happening quickly, and that care is starting to get coordinated right away for those kids. So those are some examples of our upstream metrics. And then next slide, these are chosen annually. Next slide is, I kind of got into this, I guess, the downstream metrics. So we're choosing from those, from alignment, some less reporting burden, because those are, many of those are kind of required already. As a team, my group reports 60 or 65 metrics to CMS. So choosing about 15 of those or metrics and scoring helps choose about 14 or 15 of those to be on, the incentivized set. So, kind of keeping it from that menu helps things quite a bit, just in terms of trying to lessen that burden as best we can. We know it's a lot for providers still, and CCOs. And then the next slide just talks again about the upstream. 4 are required to be in that space per Senate Bill 966, which is from the 23 session. We currently have 5, so 1 extra one in the upstream space. Next slide, we tend to staff metrics and scoring. Sorry, next slide. Where they show some interest, we'll kind of gather up all the other summaries and available data, try to break data down by realty categories as best we can, and invite presenters to that team to kind of answer questions and see what else they might consider for the set, see if there's any gaps they see is on the set, and to help kind of aid in their choices. Does that make sense? Next slide. Then we do get into some OHA recommendations. So, from public health, maybe from our dental director, we as a team kind of present choices and present some recommendations, but it really is that committee that makes the choices. Next slide, although I think we can probably skip this in the interest of time. The next slide really has the 20. So here's where we've landed for the 26 incentive measure set. So I will leave this up for a minute. Some of those that are in the upstream, so I talked about how those are kind of chosen differently. They might not be on the CMS core set, for example, and those kinds of things. But they could, in theory, be categorized under some of these other things. I mean, certainly behavioral health is kind of the main focus of the social emotional interventions, for example. And behavioral health is one of the screenings that is in those assessments for children entering ODHS custody. So there's a lot of overlap here. The top 4 categories there are really CMS's kind of characterizations and categories, and so those ones you see at the top of the set are from the core set, and we left them in the category that CMS has them in. The other 5 are on the upstream set are we're defining those as upstream, so not trying to place them necessarily in one of those top 4, but as results come back to us. So next slide. We're evaluating how CCOs do, processing payments in June. By the end of June, payments go out to CCOs, and then, as mentioned, we're from there are shared out into the provider networks. We do a kind of an overall summary report pretty quickly after that in terms of how CCO did and how the performance went at kind of a rolled up level. And then by the end of the year, we're also able to publish a dashboard, which really dives into all of these Real D categories, language groups, and we've really been able to do some interesting things the last couple of years, where you can really poke around and see different disparities by group, see different health equity issues kind of popping up in the ways that we've been able to kind of slice and present the data in that kind of a format, very interactive dashboard space. So I'll pop a link to the main report and the dashboard here in just a minute. And then I can take any questions. The next slide.
I see Stacy's hand is raised.
Hi, thanks for the presentation. I did have a follow-up. As far as for the rural communities, there was a lot of talk about transportation, access, wanting to talk about being equitable. But I'm curious, after the screening for some of these areas that are lower density population and especially provider deserts, what then? Is there any look at, so we've done these screenings, we've identified some, maybe some health disparities, but for those areas that don't have the resources, do we look at the gaps in comparison? Because screenings are only as good as what follows.
Right. Yeah, the idea of the social determinants of health screening is to eventually get all the way to kind of a closed loop referral. So we see that there's a referral and it is, met or responded to. We're not quite there yet. I think we're recognizing that there's still quite a bit of development to do there for that to be, for that to make sense and start to be the gauge. That's a few years off. I think you're right. I think OHA is certainly tracking some other challenges in rural spaces for sure. I mean, you saw that we chased down some rural health transformation dollars, and I think we'll be, trying to make some new investments in that space and new analysis in that space. I should have mentioned that one of the newest things in the dashboard this particular year is is a geographic breakout, and so that was something that that CMS kind of was kind of hoping that states would start to get there as well. So they had it kind of on their list, and also our OHA director out in some listening tours about a year ago heard that feedback and really brought that back as well. So there's a couple categories in there. You can look by urban, rural, or various regions and kind of see, where some disparities are or whatnot. The other piece of that I think is at the CCO level, making the investments with the incentive dollars that should be part of their lens. I know that for some CCOs, they make some of those investments with a committee of some community members as well, but some of those recognizing of kind of what's it taking to meet some of these metrics and where folks aren't meeting them, is it that more dollars are needed rather than less, So sometimes we incentivize good performance. Other places we got to look and say, well, maybe we need to make investments because performance is low, and if there's a structural issue, there's a rural issue, there's a some kind of access issue where dollars would be better invested in an area that appears to be lower performing, but when you dig in to see why.
Thank you. Yes, I would really encourage looking at the process for some of our providers who, or even the referrals, because if you don't have anywhere to refer, or the client can't make it to Portland or to other areas, what does the QIMS or the quality and what do those measures look like for others who do not have as many resources? And I just want to make sure that that's being highlighted.
Great input, Stacy. Appreciate that. That's an important question. And for everyone's edification, committee members and others, Sarah did post the link to the dashboard in the chat if you want to take a look at the dashboard and bookmark that. And Derek, on that, I'm not going to dig into the dashboard right now. I'll take a look at it later. But in the dashboard, you mentioned there are 65 reporting points to CMS. And are any of those, is there any information on that outside? And I know that's outside the quality metrics teams, but do you collect those, or is that a larger team effort, or is there somewhere where that is also information is also available?
I mean, some of both. My team certainly does a lot more than just the incentivized metrics. So I talked about 15, for 24, there were 15 incentivized. But yeah, there's a number of other measures there. CAPS is one I think that this group has probably heard of or had a presentation on. So there are some CAPS measures from the CAPS survey that are reported to CMS and are displayed some other places in OHA's reporting. A number of metrics that used to be incentivized or some of those kinds of things. There's more behavioral health ones. So there's a listing in the, in the dashboard, there's drop downs of what's available. I also have just posted the summary report, which is kind of more focused on, on the 15 incentivized ones and is a little bit of an overview of how CCOs did. So that might be a little bit of a primer in terms of folks before they dive into the dashboard with just a bit more of the context, excuse me. And I guess the other thing that's been interesting, I mentioned with those 3 at-large seats, how we're trying to, more and more really get community representation in those or encourage that as best we can. I think overall as a program, one area where we're moving is to try to hear more and more directly from communities and OHP members. Kind of the member voice and member experience has probably been, not at the center as much as it probably should be and deserves to be. So I think as a program, very open to ideas about that. And the other thing that I think from 2013, health equity wasn't necessarily as much of a focus as certainly as it is now. So these metrics are, you meet the metric on kind of your overall population, rather than OHA maybe taking a deeper dive in there to say, are there disparities within that? Yeah, you just met the mark, but are there groups that weren't served as well or aren't where we'd like to be? Is there a gap? And we're not currently incentivizing the closing of gaps necessarily within, so maybe you break the data down by some RealD categories and you see some pretty large disparities, and we've seen that in some other reporting. But right now, it's not geared towards, hey, let's close gaps. Let's not just make sure we've met a mark for our overall population. What if we retain some of the dollars to incentivize, real gap performance of some of those health disparities? So that's another space that we're starting to explore. So equity benchmarking would be kind of the short term for that. It'd be complex in terms of how we actually get into that space and do that, but kind of the next wave, I think, as a program. So you can say, hey, these are some big dollars, and how can we focus those more towards closing some health disparities in ways that could make a real difference.
Well, that is some excellent continuous improvement on the project. Really trying to modernize it. That's great to hear that the committee and your team are thinking about that. I mean, I could think of in my sector is behavioral health that I work in and have for 30 years here in Oregon. And there'd be a great opportunity there on child and youth behavioral health services. As we know, that's not very accessible in the state of Oregon, and that could be a great place to so many great places, but that's one of many, I'm sure, that would be good to look at and interesting to look at in that kind of thought process and infrastructure process as you build that. And I'm curious, with our new sister, and we had the ACE before, but now it is the BAC, and it's a little more formal because now it's federally required, which is full of consumers. Perhaps that's something to ponder too. Sorry to put you out there, Lydia and BAC members, but maybe not sorry. And that could be, again, that's a well-versed group full of consumers that are really quite pivotal and savvy about operations and opportunities.
Yeah, definitely coordinating to be in touch more with that group.
Yeah.
Thanks.
Cool. We have a few more minutes for questions. Do we have any other? Oh, Jerry has a question.
Jerry Weeks. I'm from Neighborhood Health Center. I'm the CEO there. And I have a question about the scoring committee. And you said you have 3 CCOs. and I've forgotten the makeup of the other 3 community members and 3 somebody.
Three measurement experts.
Right.
So, I mean, that's been a mix of some people are like at Providence Core, or maybe they're a little bit more academic. But yeah.
Yeah, I think my comment, and we've struggled with this for a long time, is really that 3% improvement target at the measures.
Mhm.
Once you're performing at the top level and say you're reaching you're at that top tier, there's a law of diminishing returns. You're not going to keep going up 3%, but the financial impact of when you drop a tier is devastating, and it'll be even more devastating as our Medicaid members drop off of Medicaid for the reasons we all understand under the HR1 bill. And it would be, if we're performing at the top tier and we're staying there, why are we asking for 3% improvement over and over every measurement period? And we've asked, the CCO, we've tried to engage in those conversations about how do we get that capped? And there's no, we never get any answers in a variety of settings. And I think it would be really helpful to have some income stability regarding the measurements and the performance going forward. That would be extraordinarily helpful.
Yes, absolutely. So let me talk about the 3%. So we set a benchmark that's fairly aspirational. It might be the 75th or 90th percentile. And then any CCOs that are above that, they just need to maintain. Any CCOs that are below that, they need to close that gap. And for quite a while, it was kind of assumed that a minimum improvement would be 3 percentage points, or a tenth of that gap towards the benchmark. That actually hasn't been as common especially since the pandemic, and for metrics that have been around a while. I think we have recognized that there's less and less improvement on something you've been chipping away at for 10 years. So you see floors. So especially for this coming for what we're in right now, or the 26 year, the metrics and scoring did drop a lot of floors. So that there isn't that 3%. You're still expected to do as well or a little bit better, but not a 3%. Many are at 2 or 1. Many there's no floor at all. And that's some recognition of measures that have been around a while, and starting to say if there's going to be a little less dollars available in this incentive program, and Medicaid enrollment and who's eligible could be vastly different HR1 kind of implications. I think that was factored in a bit. So yeah, totally agree with you. And there has been some more recent movement in that space.
Thank you so much. That's really helpful to hear.
I did, Derek, this might, and you may not be able to answer this today, but I did have a question in thinking about how we choose those measures, and how your team and the committee are thinking about leveraging that opportunity to do a variety of things as the program matures. Sometimes we think, 10 years is a long time, but in the scope of systems, 10 years is not that long. And we're still learning and improvising and testing. On all the measures that the committee has to kind of choose from, which I think is wise to reduce administrative burden. I think it's good to, when you have a big set like that, to try and align it for everyone. Are those measures standard in CMS, or are those measures part of our waiver process that we have? I guess my long story short is, do we as a state have a lot of flexibility in all 65, or is there a standard set we have to pick from CMS? How does that work so that we can get a good pool of things that work for our program?
Yeah, question makes sense. Yes. Most of them are standard. The upstream, so when I talk about 65, that's really roughly the overall number of metrics that we report in that kind of downstream space. In the upstream space, there is more flexibility, and some of that, yeah, I suppose, yeah, is tied a bit more to the waiver. So social determinants of health is actually a good example of that. So that's something that a work group here, OHA staffed with a number of community members and partners in the space helped develop an idea and started, the idea of a metric and to really explore that space of screening for all these various social needs and those referrals in that space. In the latest waiver, there's HRSN. So are we funding some of those health related social needs? I don't know how well that continues after this waiver, right? And ends in what was it now, about 18 months. So I'm not sure how well that continues, how we would need to adjust. I mean, obviously it wouldn't quite be fair to have a metric out there for something if the funding for that completely drops off based on this administration. So I do think there are places in that where we're looking as best we can. Let's just kind of standardize things, but there certainly are some issues that Oregon has chosen to go all in on or are a little bit different here. We have a metric that just counts blueberry muffins, for example. Oregon's got a lot more Marionberries than anywhere else, right? So you might have to adjust it here a little bit, or have your own metric that's slightly more tailored and make some sense. We just don't want to have 20 or 30 of those to where everyone out there has to measure all these Oregon ones and the other 65 that are required. So there's a balance there in keeping that somewhat minimal.
Yeah,
Yeah.
just with the austerity coming, administrative burden becomes more costly every day. And yeah, but we want to get meaningful measurements because that's important. We have to have meaningful measurements, but balancing that teeter-totter. I thank you for answering that. So that's interesting that we have more flexibility on the upstream measures. Thank you for clarifying that. And I saw Kaya had her hand up real quick. I think we have time for one more question. If you had a question, Kaya.
Oh, yep. Sorry. I think you answered it just now, Heather.
Oh,
but when he said that he was worried about the upcoming for social determinants and health equity and stuff, I got worried for a second, and I was going to ask him to clarify, but you did.
Yeah. And so that's good that we have some flexibility on some of those measures. And then it makes sense to me because I would assume the downstream measures are the more standard billable, old school Medicaid functions. Yeah. Okay. Yeah. Well, that's very helpful. Okay. Well, with that, do we have any more questions or clarifications? Derek, thank you for being so flexible with our questions and on the spot. As you can see, this is a very curious and supportive group. We want to know and learn and support the vision of having access to care and helping all of the parties in the system of care function at their highest performance for the sake of consumer access. So we really appreciate that and appreciate all your work at the Health Authority on this committee and tracking all those things. That's a lot of tracking and a lot of reporting.
It is, yeah. No, thanks so much for having me. I'm happy to answer any follow-up questions that come through staff or pop back to this group. And I guess I'll give a plug. We're always kind of searching for new members. So we have always have an application pool that's out there and live. Other times we're more specific about our recruitment, but we kind of always have a link live that folks can show interest in metrics and scoring or ask us questions. So yeah.
Thank you. Happy to circulate those. Okay, well, with that, no further committee member questions. Oh, look at this. We're just very close to being on time. Woohoo! Thank you, Derek, and look forward to maybe having you back in the future. Yeah.
Sounds good. Thanks, all.
Thank you. Okay. So our next agenda item is our public testimony at 10:15, and look at that, it's 10:15. All right. So I will go ahead and start that process. So public testimony, the Medicaid Advisory Committee welcomes and deeply appreciates public testimony. It is one of the most powerful ways we demonstrate our commitment to profound listening and learning. Deep listening means that we will not respond to what you share, nor will we attempt to fix or resolve the questions or concerns that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it is an important consideration for our work, and listen with careful attention, respect, and the honor that you deserve in the time that you've taken to do public testimony. We really do understand it is not easy for everyone to come and do public testimony and speak in a large setting. We want to acknowledge that time held in our meeting to hear public testimony is meant to provide a voice and a perspective from that individual and is not representative of the Medicaid Advisory Committee, its members, or the Oregon Health Authority or the Oregon Department of Human Services. Each presenter is given 2 minutes to share, and in the event that that does not feel like enough time or is not enough time, we encourage you to provide written testimony, which we commit to reading. To keep us on time, we will start a 3-minute timer for each commenter, and we kindly ask that the commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the committee chairs, co-chairs, and staff to determine the appropriate next steps. Committee staff will communicate the next steps with each public commenter. So again, please, writing your comment is also very important. So we appreciate both the verbal and the written comment. Sarah, do we have any folks in the queue for public comment?
We haven't received any requests to deliver public comment to date.
Okay, and did we have any requests for reading any submitted public comment?
Nothing.
Okay, and of course, for members of the public and committee members, those public comment are posted on our webpage, and we also circulate them to members. So please make sure that you've done that. We'll wait for a few minutes here. Well, darn. We've had so much good, robust public comment. It's unusual not to have public comment today. I would ask the committee members to be patient. Let's wait for, we have 10:15 to 10:25 for public testimony and public comment. So I'd like to wait at least a couple more minutes here in case someone pops on late. I know not everyone can be here right at 10:15 who may want to testify. Okay, we're headed into almost 10:20. My last call for public testimony. I'll drag it out here. It's amazing how long a minute can feel when we're all being quiet. We should all remember that. We should all take a minute to be quiet for every day. Let our minds rest. Right, it is 10:20. Seeing that there is no request for public comment, we will close this part of our agenda. Thank you, everyone, for your patience in making space for public comment today. On the next item on our agenda is a break. And so we will be back at 10:35. Please take care of yourself, go get some water, take a little break, and we'll see you back in a few minutes. Thank you, everyone. Oh, welcome back. Now we are official. The recording is in progress. Thank you. Welcome back, everyone. So we, as you probably have noticed today, Derek mentioned, we have a variety of things on the agenda today that are really about our function of having the opportunity to support and advise and get information from all of the different wonderful team members over at the Oregon Health Authority who are really monitoring the success of our Medicaid plan here in Oregon through a variety of means. So I just want to give a shout out again to Director Sando for reporting to us, for Derek to reporting to us, and really letting us support their work as they do the important work of evaluating the continuous improvement and quality metrics of our plan in the state of Oregon. So just wanted to say that before we dive right back into the agenda. So the next presentation on our agenda is the MAC 2025 report. So we will have that presented today and discussed. Really thank you to the MAC members who participated in this process. This is our annual report from the previous year of 2025. And I believe Lydia Dennehy, you agreed to do the report out for that group that worked on the report.
Yep. So basically, we met and reviewed Sarah's start draft, and we reviewed what we were doing and why, and then we did some review and basically said, okay, now we're going to turn it over to the MAC for more advice and refinement. We changed the order of a few of the things. They were, Sarah had them like chronologically, and we sort of grouped them by subject to be easier to follow for people who were not as familiar with the topic. But mostly we just let Sarah lead us in using the minutes from prior MAC meetings. Next slide, I guess, or yeah, I'm using my phone, so.
Take as long as you need. That takes talent. You go, Lydia.
That's all right. Yeah.
And Lydia,
so
if you need an assist, just let me know.
Okay, yeah,
Yeah.
I think I ran through our brief thing, but I didn't look at these slides ahead of time. So basically we are required to do it by the charter. We try to get it done by July, but there's a certain amount of back and forth of we say we do it, we say it, and then we get input, and then we revise it, and then we go back and forth. So
Yeah, and just to clarify, so the report that we have done historically, because it was in our charter, and we're changing some things this year because, as it happens, the feds thought that having the MAC have an annual report was a great idea, and they wanted to spread it to all 50 states, so they put it in the rule that they promulgated that created the BAC and made some changes to the MAC. And so we're doing our annual report, and we're doing it a little differently in order to meet the new federal guidelines. So this chart kind of outlines the differences between how we've done things in the past and how we're going to be doing them going forward.
Great.
I did a poor job of bringing Lydia up to speed on that history. My apologies.
Thank you for the context, Lydia and Sarah. Really appreciate that. Oh, and they did change the date, so it's more of a the government calendar year, not the actual calendar year. Okay.
Well, we get more time to kind of incorporate a response from the agency. Yeah.
Do you want me to go over more on I think, Sarah, you're basically
Yeah.
Yeah, I think we've covered this slide. We can go to the next slide, I think.
Mhm. The MAC and BAC staff drafted the report in December. The subcommittee looked at it in January. We're bringing it to you guys in February for the BAC to review. Well, first for the BAC to review, and then the MAC will vote on it in February. And then it will go to Oregon Health Authority for a response in March. And then whatever the response is from the Oregon Health Authority will go to both the BAC and the MAC meetings in April, which gives time for both parties to review it and vote in May. And then it will be published along with the response in June, which meets our July 9th deadline really nicely. This is if everything goes as planned. Next slide. If you want to get this information in another format, it's accessible. And if that's the end of the report, Sarah, I think it is. Any questions, comments?
I'll point out that we've posted both the slides and the report on our website, and I dropped the links to those in the chat. We want to see if folks had any discussion or questions about what's in the report. And that's what we've left time to do here now.
So if folks want to take just a minute to pull that up and take a peek, I know everyone has a lot on their plates, so let's take a moment just to take a peek at that. Refresh ourselves here. See, Kaya has their hand raised. Kaya, your hand's raised.
Yeah, I just wanted to say that I appreciate your voice, Heather, and the way that you take us out. It sounds like I'm on like a peaceful yoga experience or something. And I appreciate it. You're like, let's be mindful, let's take this in. Like your voice is just perfect for mental health and behavioral health. It really is.
Well, I am a licensed therapist.
It's perfect. It's like I'm going into this break feeling better today. So thank you. It's going to be missed.
Oh, thank you. Thank you.
Mhm.
And I do hope folks can, I was just screening through this, so maybe we have a few minutes to discuss, maybe I'll launch us off with that. I do like as you see, as you mentioned, Lydia, I see the difference in the format from previous years, and it looks great and very easy to read. I appreciate that. And the content looks very accurate to the work we've done. And for newer MAC members, just for some context, this letter and report really blends our annual work plan. So I do really like the new calendaring of the letters. Thank you, Sarah, for putting all your hard work into that, because it includes our work plan components, things that are brought to the attention of the MAC, which sometimes they get brought after our annual retreat, and so they don't get to be part of that work plan, but we always make space, which I think is wonderful about the MAC committee and the members. They make space for things that are urgent and important, even if it was not in our work plan. And then also including our federal requirements. So I see a nice mix of all of us hitting all of our flags this last year. Look at you. Go committee members. You did the work. Because it is a span of work for sure for the committee. And thank you that. So
So I'll just say, speaking of span of work, I want to give a shout out to Kaya, who also was on the subcommittee and worked with Lydia and I to put this together.
awesome.
I was
Appreciate
going to say the same,
that.
that Kaya gave a lot of context. I'm a new member, and so it was really helpful to have somebody who's been on there for a while, been on the MAC for a while.
Good. And Sarah, can you remind folks of who all the letter is provided to?
Yeah, it's primarily directed at the Medicaid director. So Emma gets her name on the top. And then gosh. That's a good question.
Yeah, I think we've started reporting to the OHP board.
Yeah.
Yeah, to the OHPB board.
Yeah.
And I think we talked in the committee about it possibly being set up as something to be shown to legislators. Is that correct, Sarah? Is that another committee that I'm on?
I think that might be another committee that you're on.
Sorry.
It's okay. We had because our charge is to advise the state, the governor, the Medicaid director, and not so much the legislative body. Yeah.
Oh, so will this also go to the governor's staff?
It's, we can. We certainly can. So I'm noting that we want to add the Oregon Health Policy Board and governor's staff.
I think last year when we were asked to do our regular committee update to them, I think we did use quite a bit of the previous letter in the update, which was, I thought, very helpful.
Yeah.
Yeah, along with the 101 to our providing a 101 of our federal mandate to the OHPB board. So I thought that was a helpful operational item, if my recollection serves me, which it may or may not do so well these days. Okay. Is there any additions or other comments on the content of the letter? And we have a whole month to look at this. So I would say, because we're going to vote, you guys are going to, I'm not going to vote, excuse me. All of the MAC members will be voting next month. Is that correct, Sarah and Lydia? Based on the timeline. So please take some time to dive in there and look for anything you felt may not have been captured, but boy, it looks pretty thorough. And or any other input that you may have, members, before the vote. When would you like those comments back, Lydia and Sarah, to do any modifications so that we could expedite moving to a vote? And how would that happen? Can we do that because it's a vote item, or do we have to do it in the public meeting?
I'm not aware of the.
I'll let Sarah.
Sorry, just coming off mute here. Yeah, that's a great question. Let's have things back by the I think it's the 17th, which is about a week prior to our meeting, and that will allow us to incorporate any changes into the letter and to then discuss them before we take up a vote. And I think it's fine if people want to send things back in writing, that's fine, and then we can bring them up in the next meeting to make it part of the public process, and then vote on the letter with any changes that we might have.
Thank you for the process reminder, Sarah. I appreciate that. So yes, everyone on the MAC can please commit to take a good 5 to 10 minutes to look over this and send your comments and be ready for that agenda item next month. That would be wonderful. Is there any further comments, questions about this annual process? No? All right. Well, thank you, Kai and Lydia, for doing the lift on this, and Sarah, of course. As always, thank you for doing the lift on that. And let's move to our next agenda item. The next agenda item is the Consumer Assessment of Healthcare Providers and Systems, fondly known as CAHPS, survey update. So as I had mentioned, this is another, we love to have our OHA team members who have the task of monitoring the outputs of our Medicaid plan for continuous improvement. And this is another tool that the state uses to monitor the plan. In a nutshell, I suppose. So with that, I'd like to welcome Francis Chen, Research Analyst, Office of Health Analytics at the Oregon Health Authority, to talk about this direct member data. Thank you.
And I'll say that I just noticed that Francis just joined.
Oh.
So she may not have heard her introduction, but Francis, whenever you're ready, we are ready for you.
Oh, wow. Okay, thank you.
Sorry,
Actually, Jen will be presenting today, so I don't know if Jen is online yet.
Oh, yes, we're running a little bit early from our last item.
Okay, yeah, we were anticipating 11 a.m., so
apologies.
Check in with her. I can go ahead and get us started, though. I don't want to, delay your schedule. Okay, great. So the CAHPS. So CAHPS is the Consumer Assessment of Healthcare Providers and Systems. It is a survey that OHA sends out every year. The OHA asks Oregon Health Plan members about their experiences with healthcare. And this is a survey that is nationwide. We are mandated to send out every year, and every state does complete it. And it began in the mid-1990s. Okay, next slide, please. So we ask a series of questions related to many different topics. This may include the rating of all healthcare, rating of health plan, getting care quickly, getting needed care, how well doctors communicate, and customer service, coordination of care, as well as access to dental care. In this year's survey that we are currently starting to field, we've increased the number of access to dental care questions, and we are also anticipating that this coming year, the survey will drop a lot of the COVID-19 related questions. And we are anticipating that hopefully we will have a larger sample size this year as well. Next slide, please. So we ask a range of demographic information within the CAHPS survey. It of course includes race or ethnicity, language, disability, sexual orientation and gender identity, as well as age, education, physical health, and mental or emotional health. And all of this information helps us parse through the results of the CAHPS survey to look for any potential disparities between groups, as well as giving us more insights about the respondents who respond in general. Next slide, please. So the CAHPS surveys OHP members at all coverage plans, and this includes members within the Medicaid, of course, as well as Healthier Oregon, OHP Bridge, as well as Open Card, also known as Fee for Service. Next slide. So surveys are delivered every year between 45,000 to 90,000 surveys are sent out each year, depending on our budget for the given year. And then the survey is delivered in 3 different ways, including over the phone, through web, or through the mail. Typically, members receive an invitation to complete the survey in the mail, and then they are given options to either complete it over the phone or on the web through a browser. In addition, the surveys are currently fielded in 5 languages, including English, Spanish, Russian, Vietnamese, and Chinese. Next slide, please. So now it's important to go over what we've updated for measurement year 2024. This year, or I should say last year, we've updated the REALD and SOGI questions to align with our current standards. So that would mean that the REALD questions were expanded in order to allow respondents to select more granular race or ethnicity groups. And the same goes for the SOGI questions. So there are a lot more options for each of those types of questions that members could select from. In addition, we expanded the surveys to 3 additional languages, which are Russian, Vietnamese, and Chinese for this last year. And as I briefly mentioned before, we've removed the COVID-19 questions. Next slide, please. So here you can see a chart that shows the number of members who respond to the survey every year, starting in 2018 through this last year. We can see that after the pandemic in 2020, we had a brief decrease in the number of respondents, but we have since expanded our sample since then, and so we did see an uptick in the number of respondents in our 2022 survey, for instance. And since then, we've continued to receive responses in the range of 5,000 to 6,000 respondents every year. And you can also see here that this is broken out by our adult survey and children's survey. So there are 2 sets of the CAP survey. For the children's survey, the CAP survey is given to the children's caregiver or parent, and they respond on behalf of their child. Okay, next slide, please. And now I'm going to pass it to my colleague, Andy Parker, who I hope is on the call now. Yes, I do see him here. So Andy, if you want to please tag team.
Yes, I am on the call. Can you hear me?
Yes.
Thank you, Francis. I'm Andy Parker. I'm a research analyst in the SCRIMSR team in health analytics, and I work closely with Francis and Jen Davis on the CAP survey. And so what we want to do is just give you a little bit of a picture of what's in our dashboard, the type of information that we capture from the survey data. And this is just looking at one specific question about getting needed care. And this is what we call a composite measure. So it's a combination of 2 different survey questions. One is asking adults if they usually or always, if it's usually or always easy to get the care, test, or treatment they needed, and could they usually or always get an appointment to see a specialist as soon as they needed it. And so this particular slide and the chart that's in the dashboard is showing the gray lines are the different CCOs, the blue line is the CCO statewide average. And then we've also included the Medicaid national averaging as well. That is not in the dashboard yet. We're exploring ways of getting national averages into the dashboard so that we can compare ourselves to how other states are doing. Next slide, please. So this is the same type of slide showing the variation by CCO, and this is the getting needed care metric or getting needed care measure for children. Again, same questions, but same kind of information by CCO, and this again is comparing the statewide average to the Medicaid
national average. So in this case, the CCO statewide average is running about 4.5% below the Medicaid national average. So again, this is the kind of thing that gives us an idea of how we're doing nationwide. Next slide, please. Francis mentioned some of the changes that we made in the survey 2024, which now allows us to do a lot more work, disparity work. And this is looking at disparities by race and ethnicity, disparities by spoken language, and disparities by disability. So again, this is kind of looking at the same measure we looked at before for adults for 2024, but looking at race, ethnicity disparity. And this is race, ethnicity disparity both across aggregate groups, the groups that you see on the left-hand column, as well as disparities within each of those aggregate groups. So when you look at the disparity across the aggregate groups, the Native Hawaiian and Pacific Islander adults had lower reported rates compared to the other groups. And then when you look at disparities within a group, the white aggregate group has the greatest disparity or the greatest gap of 6.3 percentage points. When you look at the dashboard, everything, you can hover over each of these data points to see what that gap represents. And in this particular case, the gap is between the Polish white subgroup at 75.9 and the Irish 82.2%. So this is one of the things in the new dashboard. For instance, in the white category, we increased the number of subgroups in the survey from 4 to 10. So some of these disparities that previously were masked because we only had 4 subgroups, now we can get at some of these things that might be more interesting things that people want to look at. Next slide, please. So again, this is the same thing with children for 2024. The same measures the rating of getting care. In this case, the Black and African American children had lower reported rates compared to the other race and ethnicity groups. And then if we look at the gap again is in the white aggregate group. And the interesting thing about this was that the gap goes from the Irish subgroup, 71.1, to the English subgroup at 85.5. So that gap is 13.9%. So again, this is the kind of disparity that we never could see before, and might be something that we can look at in the future. Next slide, please. So again, where can you find CAHPS results? The information that we were just presenting, that's all in CCO metrics dashboards. And we've got a link to that dashboard on this slide. The information is also in what we call a banner book, which is created by our CAHPS vendor. And the difference there is that the banner books really get into the detail of every single question that is asked in the CAHPS survey, whereas our dashboard selects specific questions and measures that we've reported over the last several years. So again, if you're really into getting into the weeds, you can look at the banner books and see what the rates are for all of the questions in the survey. Next slide, please. And now we'd like to open it up for any questions.
that would be questions for me or Francis or Jen Davis, I believe, has joined the call today as well. And then Francis, you might also want to talk about the QR code that has the survey for people to make any comments on, both during and after this presentation.
Yeah, sure. Thank you so much, Andy. So on screen, we have a QR code to our presentation survey. We would really appreciate it if you'd just take a minute or two to complete it. Within this survey, we would love to learn how you currently use CAPS data, if you do, or how you would like to use it. And in addition to that, we are now thinking about how we can make CAPS results more accessible and helpful for your work. And so at the end of the survey, we will also ask what your preferred way of learning about CAPS results is. So that could include either an interactive dashboard, an infographic, a 2-page summary, or an annual presentation like the one that we're giving to you right now. This is just for us to know so that in the future we can provide better, high quality data products for your use. And with that, thank you so much. And if you have any questions, please feel free to go off mute and ask us.
Thank you for the survey for the members so that we can communicate with you about the reports. That's amazing. And 2, thank you for the links. I was going to ask if the links to those particular things were going to be in the PowerPoint. So when Mac members have that, they can easily find the links instead of having to search for them. But I know we also posted them in the chat here. So that's super helpful. Thank you. And I see Caroline has a question.
Good morning. I'm Caroline. I'm one of the co-chairs and also a family medicine physician. And I'm not seeing in the, thank you for the links, but I'm not seeing in here, but I'm curious about if there have been changes in timing of access to PCPs and specialists and differences between rural and urban areas, and if there have been improvements in how available patients are able to get those appointments.
I think I can answer that. Francis, you can chime in. What we presented in this presentation was just the access to care metric, or the getting care metric. There is a metric, a measure in the CAPS survey, which previously we called access to care, which got to the things that you're looking for, access to primary care, that kind of thing. Within the CAPS survey, that's actually technically called the getting care quickly measure. So if you're familiar with something like that, that's where you find it in the dashboard. As for the geographic disparity, the geographic disparity is available for administrative-based measures, but not for the CAPS survey. So the proxy for a geographic disparity would really be the measure is distributed across CCOs.
Thank you. So it's a separate metric for the timing to appointment. Am I understanding that correctly?
It's getting care quickly, meaning do you feel like you got care as soon as you needed it, or you got an appointment as soon as you needed it?
Versus getting care, period.
Yes, getting needed care is kind of the getting care period, either with a primary care tests or lab work, and getting needed care with a specialist. That's what the getting needed care is. The getting care quickly is, or getting care as quickly as.
Thank you for clarifying that difference. I appreciate that. I did not understand that difference.
Stacy?
Hi, my name's Stacy Shaw, so I work for Jefferson County Public Health. Just to kind of go off Caroline's question, I was curious for this for interpretation. So people who have a phone, have access to internet, or have a address are the ones that are answering the survey. Is there any work being done with partners in shelters or other areas to capture some of the other parts of populations that don't have those three things that were listed?
Thank you, Stacy.
The information.
Oh, go ahead.
Go ahead.
I was
Go
actually going to pass it to Jen because I think it's more of a fielding question, but Andy, if you wanted to first answer.
I would agree it is a fielding question, but the information that we have is limited to what we have, and my guess with the address and phone numbers. So if we would let respondents or potential respondents know that there is an online survey available by a phone call or a letter. We don't have the information, as far as I know, about shelter. If somebody is if their primary residence shelter. Jen, if you want to follow up on that.
Sure. Yeah, Andy, I think you hit the high points. And hello, everyone. My name's Jen Davis. I work with Francis and Andy on the quality metrics surveys and reporting team that manages this survey. Yeah, to answer your question, Stacy, there's not currently work being done specifically with community partners or shelters to help the population who may not have an address or a phone number where we can reach them. I think that's an interesting idea and certainly something that we can take back and try to explore a little bit more. We do have a bit of sort of awareness outreach, I would say, to some community partners, but it's been more in the realm of like community partners getting questions from individuals who received the survey, either in the mail or by phone, and they may have questions about like, is this a legitimate survey? Should I answer it? What is this about? It's been more in building awareness that way rather than actually having them like work with either folks in their shelter or in their community to actually like one-on-one get them to answer this survey.
Okay, thank you. I had one more part of the question too. So it's safe to interpret that the folks that are answering this have some kind of housing, because they have an address, they have access to a telephone or internet. So in rural areas, that can be a problem, just especially with the access to Wi-Fi or internet in general. But also the readability or the average grade level of this, and how long approximately does this survey take to answer? Because I'm kind of thinking of, I would like to know who's answering the survey for interpreting the results. Because if we only have certain parts of our populations answering, that for me in a public health, it doesn't help me to help respond to some of the gaps. And so I just, trying to understand a little bit more of how this survey is set up would be helpful.
Yeah, thank you for bringing that up. That's a really valuable perspective. One data point that we do capture that, to be honest, we haven't explored much, but it could be useful given your comment is the survey does ask individuals their highest level of education completed. And so it might be interesting to stratify and take a look at the results based on that, or to see, you know, are the vast majority of our respondents saying that they have a high school education or a college education, or are we getting a fairly decent representation from folks who may have a lower level of education? That's not something we've explored, to be honest, but the data is there, and that's something that we could do. And then to your other question about length of the survey, unfortunately, the survey is quite long. The survey is primarily, as Francis probably went over this, I'm sorry, I joined a bit late. Primarily the questions are written at a national level by AHRQ, and so we sort of have to stick to their language, although my understanding is that they try to write to an 8th grade level. And then we do have some additional questions, mostly in the demographic reporting, so real D and SOGI type questions that come from the OHA standards. So we don't have a ton of ability to change them, unfortunately. And the length of the survey, it is quite lengthy. I think we estimate 20 to 30 minutes for completion, although an individual is able to stop at any point and reply. They will be considered a valid reply, even if they didn't answer all the questions.
That's super helpful. That actually answered one of my questions about how standardized are the questions across the country. I did have one follow-up on that. Where is this posted federally with the other states? If there's a link for that, that would be great.
Yeah, let me find the link for you. This is part of the CMS core set reporting. So all states are required to report to CMS, and there is a publicly available sort of data set where these measures are reported. So I can find that and put it in the chat for you, or if I don't find it in time, I'll email it over.
Great. And then I did have another question. We have quite a few newer MAC members coming on this year. And just for a little context, if you could share, so how does OHA utilize this CAPS information to inform its workflows in managing the Oregon Health Plan and other parts of all the different parts of the Oregon Health Plan and the different workflows that the authority uses to manage that plan in a variety of ways? How does this survey, it's great data, but I think it's good for the MAC members to understand how this data is used to improve the operation of the plan.
Yeah, great question. I'll take a first attempt at it, and then Francis and Andy, feel free to join in. First thing I would say is that we can definitely be better at using the data. I think CAPS captures a whole lot of data, and in some ways it's not super user-friendly or accessible to even to folks in the agency with data backgrounds, because it is pretty vast. One of the things we are doing to attempt to make that easier is developing a new reporting tool that will go live by the end of the year is our plan, and doing outreach to a lot of groups across the agency, yourselves included, also our QA folks, our quality improvement folks, our CCO contracts folks, ombuds and others, to try to really inform them that this data exists and ask them to use it if it's relevant to their work. It is one of the measures, the access one, that access to care / getting care quickly, that Andy was mentioning, is a measure in our strategic plan. So that's monitored by leadership on an annual basis. It's also in the past been a part of the quality incentive program that CCOs earn incentives for. It's been several years since the CAPS measure has been included in that set, but the Metrics and Scoring Committee consider them for inclusion each year because they are a part of the CMS measure core set from which Metrics and Scoring can select the quality incentive program measures. And then also we do have sort of ongoing meetings with, teams from our dental and oral health and things like that, just to try to show them what data is available through CAPS and perhaps how it could be useful. But it's definitely an area where we're looking to improve across the agency. And Francis or Andy, would you add anything to that?
I don't have anything to add. Well said, Jen.
Well, thank
Yeah,
you.
I would agree. Yes, well said. The only thing I can say is that this is part of our presentation here, part of a roadshow to a number of different potential stakeholders to see if the work that they do can be informed by CAPS more than it is today. And so there's always additional opportunity to use.
And I'm sorry,
information, hopefully additional information as well.
Sorry to interrupt, Andy. I actually remembered one more way that it is or has been utilized in the past and hopefully will be in the future, which is through our quality improvement team who works with QHawk, the Quality Health Outcomes Committee, which has medical representatives from all of the CCOs. And prior to a few years ago, they were using this data from CAPS in close concert with grievances and appeals and data from the ombuds program to kind of triangulate, what is the member feedback. My understanding is that work has not been super consistent over the last couple years as we've come out of the pandemic, but we are working closely with Lisa Bowie to try to get that work hopefully restarted.
Oh, that's wonderful, because that's Lisa presents to the MAC quite frequently. And I think one of the things that we've put in our work plan in the MAC and that our team, our staff support has really helped us do as an advisory body is ourselves just how do we understand all the rich data that is being collected and actually put it to use in an efficient and effective manner for continuous improvement. And we're trying to do that ourselves as a MAC and really appreciate your history, Jen, on how it's been used and ideas of how it could be used effectively. Because as we enter times of austerity, working smarter, not harder, is really, really important as we have to do the same amount or more with less if we're thinking about our near future. So really appreciate that. I think hopefully that's helpful for MAC members to understand and think about the scope of the work that we have at hand in our work plan and in our required activities. So thank you. Is there any other questions for the CAPS team? It's great work. And I won't have time to do the beautiful QR code during the meeting because I'm hosting. But if we could, I don't know how I'll find a way to do that so that I can do it after the meeting. I don't know if any other members have that struggle, but if we can get a way so that we can get access to that post meeting, that would be great.
Great. We do. There is a link that acts the same way as the QR code, and Francis has dropped that into the chat as well.
Oh, which is it? Oh, darn.
And then, yeah, and we can certainly share it out in our follow-up email to the MAC
Oh,
members.
thank you, Sarah. Thank you for
Sure.
making my life more simple. I so much appreciate you. Okay. Oh, thank you, Francis. You are on it. Okay, thank you. So members, you'll see the link there for the survey. Thank you. All right, I'm bookmarking that right now. Excuse my attention gap here.
I'll just thank you again for the opportunity to present today. And if you have any additional questions, feel free to reach out to us. And we look forward to hearing your feedback either through the survey or via email.
Well, thank you so much. I see no further questions. All right. Take care.
Thank you very much.
Thank you, everyone.
Bye-bye.
All right. Well, now look at us. We are like ahead of time. Good job, MAC members. And asking good questions. Excellent work. So our next agenda item is our MAC discussion. And so we'll start off our discussion time with some announcements. So with that, I'm going to pass off to Sarah so she can share some of those announcements with all of you. Thank you.
Great. Thanks very much. One, just a standing reminder to complete annual trainings required by law, the discrimination, harassment, and the information privacy trainings in Workday. Where I'm just going to keep this as a standing announcement, and we'll let us know, let me or Tom know if you're having any difficulties, and we'll follow up with you. I also noticed that we have been joined by our newest MAC member, and not to put her on the spot, but Dr. Ahmed, if you wanted to introduce yourself, this would be a good time.
Hey, good morning, everyone. Way to not put me on the spot. No, it's totally fine. I'm just not in the space where I can turn my camera on. I hope to be fully available for the next one. My name is Asma Ahmed. I use she, her pronouns. I serve as the dental director for Multnomah County Community Health Center. If any of you are familiar with that, yay. If you're not, we are Oregon's largest public health center, and we have 8 clinic locations in Multnomah County. And we also have a student health center that provides preventive oral health services in 98 schools within Multnomah County. We also have a mobile van that has primary care and dental. I'm here as an oral health representative, and I appreciate the committee giving me a chance.
Welcome. Thank you for being here.
Thanks very much. And as I explained earlier in the meeting, we knew that you weren't going to be able to join us for the entire meeting, given the proximity between when you were appointed and when this meeting was scheduled, and the difficulty of making your calendar clear for that. So appreciate you coming for the part that you're able to be here, and very excited to have you on the committee. And so we do have changes on our committee, and one of them is that we are, as you all know, losing our chair, Heather Jeffress. I see she's waving. Are you waving goodbye, or are you waving?
No, I was clapping for welcoming Asma Ahmed, our dental doctor. Yay. We're so excited to have our dental position filled. So thank you so much. Really appreciate your service. I wasn't clapping because I'm leaving. I do really enjoy my time here at the MAC.
Great. It's nice to see all the welcoming words. I may have moved off that too fast, but anyway, yeah, it is Heather's final meeting, so I wanted to open it up if there's anything folks want to share with Heather before we're not able to in this way. We all know that we can pick up the phone, but
Heather, I've genuinely appreciated your mentorship as co-chair and just smiling face, and that you always have very probing questions that get to the heart of the matter. So you are going to be very missed, and I hope we will run into each other outside of this space on other committees and personally. So thank you so much for serving on this committee. It has truly been a joy getting to know you and working with you the last almost, I guess, 3 years that I've been on this committee. So thank you so much.
and I see lots of, heart reacts and that kind of thing. We also have a little set of notes that people left for you that I will share with you after the call, since I
Aw.
figure out how I do that. But we really are very grateful for your service to the MAC over the last 4 years, and the last couple in particular as co-chair. It's been really great to work alongside you and have you in this partnership.
Well, thank you. I really, like I said, this is, I serve on many committees and work groups, and I think the work of the MAC is extremely important. And I think we always end up with a wonderful group of folks that are wonderful to work with. And I really appreciate the members and Sarah and the whole team in creating a structure that supports us to do the wide swath of mandated work, and also the self-prioritized work that comes to our table in managing that balance of items, because it's a lot and there's a lot going on. So thank you everyone for your service. I hope your time is meaningful, and that you enjoy your time. And Caroline, it's been just such a pleasure to co-chair alongside you. I just really appreciate it. So Again, thank you, everyone. And yes, I probably, how I ended up on the MAC, like many of you, is I just was attending regularly as a member of the community. So you may see me in that way still. So I appreciate it. So I think with that, are we on to Rose, Thorn, Bud, and Closeout?
One quick other announcement.
Oh, thank you.
We are I'm really happy to say that Stacy Shaw has agreed to put her name forward. We will have a vote in February. I think we're not quite at the point where we're ready to do that, but we're going to put that on our agenda in February, and I hope we'll welcome Stacy as our new co-chair very soon. Okay, that's all the announcements I have. So I think, is there other discussion that folks want to have? Any synthesis of the meeting that anybody wants to talk about? We've heard a lot about different ways that we measure CCO performance and a lot of meaty stuff. I don't want to close out that possibility if there are things that folks want to share as last thoughts before we close out this meeting.
I'll just take my prerogative as last meeting. I've been pondering this and the agendas are so great and we have really made so much progress on looking at other work groups, other surveys, other data points that we talked about in our retreat last spring. So thank you to Sarah and the team and Director Sando's leadership in helping the MAC kind of making progress towards that goal. So I would just say that seems so important right now with how we're the environment that we're functioning in on the plan, and to really work smarter, not harder. And how can the MAC continue to support our teammates over at the Oregon Health Authority to kind of tie the knot on those. And I know the other one that we've, because there's so many others, the Ombudsman report, the parity report, the CAPS report, looking at the metrics and how can we use these things really efficiently and effectively. And so I just want to put that out there that I think we made a lot of progress. And how do we work with our fellow committees so that we're more effective? Because we know all of us have a lot on our plate, and it's wonderful to have all these committees, but we also don't want to burn people out by having to attend so many multiple committees. And I know OHA is looking at that too. So I think it's a really meaty and meaningful work product that was from the retreat last year. And I think I feel like we've made some progress. So I hope the committee continues to chug away on that.
Great, thanks. Any other final thoughts before we close out with our Rose, Thorn, and Bud? All right, seeing none, I'll ask in the spirit of continuous improvement for Roses, things that you enjoyed about the meeting. Thorns, anything that felt a little pokey today, and then Buds, anything that you'd like to nurture in the future.
A rose is that we did not completely overfill our agenda today. I think this might be a first in my time on the MAC. So while I'll also lament that we have 25 minutes that we could use, it is nice that we're not totally running behind schedule.
Okay. Thanks for the comments in the chat, which just says great meeting as always. Shucks. Any last? Nope. All right. Well, with that, we'll meet again online on Wednesday, February 25th at 9:05 a.m. And we will see you all then. Take care.